ATI seminar. So thanks for joining us. Excited to have a group of my friends and colleagues presenting today about the hub and spoke model in lung transplant care delivery. So I'll just start, of course, today acknowledging that the U of A is located on Treaty 6 territory, and we should always observe and respect the histories and languages of First Nations, Métis, and Inuit people, and all First Peoples of Canada. I also just wanted to thank Paladin for the ongoing support of this seminar series. They've really made it possible to be sustainable. And just a reminder to register and submit abstracts if you haven't already. Number one to ATI Research Day 2025. That's up and coming in March, as well as the International Symposium on Systems Immunology and Transplantation, co-hosted by the ATI and the National Institute of Allergy and Infectious Diseases, and that's taking place in Edmonton in a synchronous fashion with ATI Research Day. Today I just want to introduce each of our speakers. I'll give you a little bit of information about them. You may know some of them already, and some of them you may remember from previously when they were here. So first off, Dr. Thakrar, Mitesh Thakrar. He's a lung transplant physician and pulmonary hypertension physician from the University of Calgary. So he completed medical school and medicine and pulmonary residency at the U of C, and then pursued fellowships in lung transplant at the University of Alberta here with us, and then pulmonary hypertension at the University of Newcastle in Newcastle upon Tyne in the UK. He is a born and bred Calgarian, and so he returned to Calgary and has been on faculty since 2011. And currently there as a clinical associate professor with the divisions of transplant medicine and pulmonary medicine. And he serves there as the director of the Southern Alberta Transplant Program and division head for the Division of Transplant Medicine at the Cummings School of Medicine in Calgary. Dr. Fenton, Dr. Mark Fenton is joining us from Saskatoon in Saskatchewan. So Dr. Fenton completed medical school medicine and respirology training at the U of S, and then pursued additional lung transplant training here at the U of A, and then returning to his hometown in Saskatoon to establish the Saskatchewan Lung Transplant Program, where he is and remains the medical director. Mark also wears lots of different hats. He's the program director and the division head in the Division of Respirology, Critical Care, and Sleep Medicine at the U of S, and is now physician executive and of integrated Saskatoon Health in the Saskatchewan Health Authority. So lots of different roles, and a busy guy. Dr. Weinkauf, you guys probably will know Justin Weinkauf. He's the medical director at the U of A Lung Transplant Program, and his transplant career is focused in quality clinical care, postgraduate medical education, and research and administration. And as an educator, Dr. Weinkauf has led transplant fellowship training locally and nationally, including the past chair of the area of focused competency in solid organ transplant, which is one of the reasons the U of A offers that in transplant training now, and also and that's offered by the Royal College of Physicians and Surgeons of Canada. So he serves now as the program director of the University of Alberta's AFC SOT program. And then finally, last but not least, Dr. Steve Grocholski is joining us from Winnipeg in Manitoba. And so we truly have a very multi representative group here from all over the Western and Central Canada. And Dr. Grocholski completed medical school at the University of Limerick in Ireland, followed by an internal medicine and respirology residency at the University of Manitoba. And then Dr. Grocholski completed a lung transplant fellowship with us at the University of Alberta several years ago, and returned to Manitoba in 2021 as a member of the Manitoba Lung Transplant Program. And his additional roles there are with the Department of Internal Medicine and Respirology, with a focus on postgraduate medical education and service delivery. So thank you very much to the four of you for putting this together in this discussion on a hub and spoke model of lung transplant care delivery. which is quite a unique model in this world and in the world.
For agreeing to undertake this talk with me. And as Kieran said, today we're going to focus on the current model of how we deliver lung transplant care across the Canadian prairies. I think myself and Dr. Fenton continually say that at some point we should really publish this because it is unique. We haven't come across any other programs that have described a similar style of providing transplant care. And certainly in terms of the geography that we cover is absolutely massive. And so I think it is something we should be proud of. In terms of disclosures, mine are listed there. None of the other speakers have any relevant disclosures, and certainly mine are not applicable to today's discussions. I am currently presenting from Calgary, and I would like to acknowledge that the University of Calgary and the City of Calgary are located in the heart of southern Alberta, which is the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprising the Siksika, the Pekainai, and the Kainai First Nations, as well as the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. And the City of Calgary is also home to the Métis Nation of Alberta Districts 5 and 6. And this is one of my favorite photographs that my kids ever took, which is on our usual bike path, which is fantastic. So the objectives today, firstly, I'd like to review and I'd hope by the end of today that you have a thorough understanding of the data that exists for hub and spoke models with regards to transplant care delivery internationally. We'll also talk a little bit about the current care delivery paradigm in lung transplant care here in the Canadian Prairie Provinces, and also hopefully give you a good understanding of the current volume and demographics of our lung transplant program in Alberta. So the hub and spoke model is well established. We hear mostly the hub and spoke model referred to in aviation, as that's kind of the most common way that aviation industries work. It's noted in a lot of different organizational structures where one uses a central hub to connect to various outlying spokes. And certainly if you've ever had the misfortune of flying on Air Canada, you'll have probably experienced flying through a hub. But if you do a quick AI search, I don't think in 2024 you can give a talk without doing a search on AI. You can see that hub and spoke models have been noted in all sorts of different areas, and including the last one here, which Google AI speaks about using rehabilitation services. And I'll speak to something analogous to that in lung or in transplant medicine. And if you do a chat GPT search of hub and spoke models of transplant medicine, there are a number of centers that do advertise that they offer a hub and spoke model. So the University of Pittsburgh, the Mayo Clinic, and California Transplant Donor Network, all in the United States, do describe that they have a hub and spoke model that makes it better for patient care. Interestingly, they have no data to back up their outcomes in there anywhere that I could find on their web pages when you go to them. And similarly, there's a chain of hospitals in India called the Apollo Hospitals, which do similar. And again, no published data that I could find. That said, there is some sparse data behind the use of a hub and spoke model, and doesn't pertain to lung transplant, but there is some transplant data that we could use as a basis for which to embark on this kind of a journey. And of course, I think this is relevant to us in Alberta because aside from renal transplantation, 3 of the big 4 organs are transplanted only in Edmonton, but our patients come from a huge geographic area. I certainly think, the Prairie Provinces are as big or bigger than most countries. And certainly we've all seen this, even the travel that we ask patients to undertake to go to Edmonton, just being 3 hours away from us in Calgary. And I'm sure the folks in Manitoba and Saskatchewan feel even more so. But patients have told us that they are not going to undergo transplant because they can't imagine how they would actually live in Edmonton for 3 months, and they can't afford to pay 2 rents and have expenses in 2 cities, etc. And so we've had patients who have declined SOT simply for that reason alone. Nonetheless, we've tried to remove as many of these barriers as possible using spoke centers. And as Kieran spoke about, we've established spoke centers now in Calgary, Saskatoon, and Winnipeg to try and mitigate this barrier to transplant. There are some current data that we can look at, and primarily driven by the liver transplant programs in the United Kingdom, which have demonstrated what outcomes can look like with a hub and spoke model. By way of background, I'd like to bring to your attention this paper from the American Journal of Transplantation from 2019, looking at what the impact of proximity to a transplant center does in terms of outcomes. And again, this is UK-based data. And what they did is they looked at the 7 transplant centers in the United Kingdom, and then plotted every patient who was listed for liver transplant and the center that they were plotted at. And so you can see based on the color code that, of course, patients tend to be listed at their nearest geographic center. There are some giant holes in the map where there are no listings, but again, there are also less patients in those areas. But what was interesting is you can see here on the right that the highest chance of listing per 100,000 patients occurred in the postcodes that were the closest, or in the postcodes that were closest to a transplant center. And in fact, the blue dots on the left-hand side tend to be as far away from a transplant center as one can get in the United Kingdom. I'll remind you, though, that the drive from London to Edinburgh is, without traffic, is no more than about 6.5 hours. So you can put that into context of our Canadian geography and realize that if these disparities exist in the United Kingdom, they're probably only going to get magnified by our geography. What they also demonstrated was very clearly that the travel time to your transplant center impacted your chance of survival, and the chance of being removed actually from the transplant waiting list. And so again, they did it based on average driving time. The blue line represents a commute of less than 1 hour to a transplant center. But as soon as you're more than an hour away in the United Kingdom, your risk of either delisting or dying while waiting for a liver transplant is significantly higher. And this actually was replicated in the United States, where, again, those that had a commute time of an hour or less, or roughly 30 miles, had a better chance of receiving a transplant, and receiving a transplant faster. This did correspond at the same time with the Royal Free Hospital in the United Kingdom, which is based in London, creating a hub and spoke model with some other centers based in the southwest of England. And they make the claim that their care model does increase access to liver transplantation. And so this is their model of how they deliver care. So there's 2 parallel but similar processes depending on where one is located. So if the patient is located within the confines of London and is attending the Royal Free Hospital, they undertake a very intensive 5-day admission for a workup, and that's a pretty typical way of assessing transplant recipients in the UK. That was exactly what we did in Newcastle when I was training there. Is you would admit patients and you'd do their entire battery of tests in 5 days. And then at the end of that would culminate with a meeting with surgeons and being consented for the OR right then and there, and being put on the active waiting list. If you belong to a spoke center, the workup really occurred primarily as an outpatient with a very short 2-day intensive stay at the Royal Free Hospital, again, to complete the last few tests that were transplant specific and couldn't be done elsewhere, and again, to meet the surgeons and be listed. I don't really understand what local waitlist management was, and they don't speak about it in their paper. That's not a route that we've taken. The waitlist is certainly managed with solely with our colleagues in Edmonton as it pertains to lung transplant. But certainly, I think we all input into the listing and delisting of patients based on our local assessments of patients on a routine basis, and it allows our group in Edmonton to focus more so on their local patients and touch base less often with our patients that are more distant. And then similar to our program, there's a local post-transplant follow-up with input from the Royal Free Hospital as needed. So they did a reasonable job, I think, of looking at the types of patients and the demographics of patients that are referred between a spoke center and a hub center. I do want to point out a couple of different things. So one is there was a difference in the indication for transplant with a substantially higher number of hepatocellular carcinomas being referred for transplant at the spoke centers than in the hub center. So there's a question raised there of what's going on with patient selection at the two centers. And similarly, if you look at the percentage of patients that are listed upon presentation, there is a difference, right? So the hub centers reject about a third of their patients, whereas the spoke centers, about a quarter of patients are turned down for transplant. And it does beg the question of whether or not spoke centers are being overly selective before bringing patients forward to the Royal Free Hospital. And if that is the case, then are they potentially missing candidates for transplant that would have been more likely to have picked up in the hub center, or is there a bias there of some sort in terms of who's being selected? So it's something to keep an eye on, and something I think we've all spoken about as we've set up our hub and spoke model as well, that we want to make sure that the demographics of our patients look similar. Nonetheless, that's the model they've employed, and other groups around the world have had similar models of hub and spoke care in liver transplant. And so there was another paper that looked at actually care delivery of liver transplant care in both Canada and the UK. This looked at our colleagues in Ottawa, who again are not a surgical center for liver transplant, but receive mostly patients from Toronto. Unfortunately, this study does not include a control group being the hub center. So these are both spoke centers, Nottingham and Ottawa. And I don't know why, but they have this consistent typo in their charts when it spells Ottawa. But what they did show was that their survival between these two spoke centers were identical. And interestingly, not that dissimilar to overall survival based on international published literature in terms of the expected survival of a liver transplant recipient. And so despite not having a control group, they made the assertion that care in a spoke center does not jeopardize survival of a patient. There were some interesting findings that perhaps speak to the way we manage immune suppression overall in North America compared to the United Kingdom. Certainly, I think we see similar trends when I just think anecdotally about patients that I followed in the UK versus here. But there is a higher risk of end-stage renal disease, a higher risk of major adverse cardiac events, and an increased risk of de novo cancers in patients who were residing in Ottawa as compared to Nottingham. And I suspect that may reflect higher rates of immune suppression, but I don't know that for sure. But those were the only differences that they could tease apart between their two practices. And interestingly, if you start reading about heart transplant and the hub and spoke model, it seems like the whole hub and spoke model of heart failure care really originated here in Canada. And instead of using a geographic paradigm, the heart failure folks use a intensification and de-escalation paradigm based on how the patients are doing. So the spoke tends to be family practice with this idea of escalation to a community hub or a heart failure clinic, and then ultimately up to a tertiary node, which are our advanced heart failure services, those that can offer MCS and heart transplant. And so I think this is sort of how we all practice medicine in Canada, but they've solidified and codified this as a hub and spoke model with really important emphasis placed on two-way communication between the different levels so that folks are continually being updated on how patients are doing. In terms of lung transplant, there really is very sparse data. There are two abstracts and purely abstracts that were presented at the ISHLT meetings in 2015 and 2021. The 2015 presentation was from Adelaide, where their spoke was that of Melbourne. Again, it seems to be only a single spoke, and what they showed there was their survival and rates of bronchiolitis obliterans syndrome were no different, regardless of which of the two centers you were managed at. There was really not much more data presented in the abstract than that. And then in Uruguay, they similarly employ a hub and spoke model with a transplant center in Buenos Aires. There's no lung transplant program in Uruguay, and so the surgeries happen in Argentina, and then the patients are brought back. And again, the only thing that they reported on was the total number of transplants done, as well as crude survival, which was no different than patients who were receiving a transplant in Argentina. But that's all the data that they presented. And so that's all that exists in lung transplant at the moment. So my takeaways from the data that we have is I think there's reasonable data to say that you could probably obtain similar results managing cares in a satellite center. I suspect there is an increased access to transplantation, and I think we all feel that intrinsically. I do think we need to be a bit wary of being either overly selective or having referral biases creep into our practices. And it's important that all centers are practicing very similarly, and that probably requires ongoing discussions. And I think there's an opportunity here for us to not only look at this. I mean, we certainly should look at it in the lung transplant group, but perhaps this is even something we can think about as a multi-organ presentation, given that we have three hubs based in Edmonton and numerous spokes across the country. So I would like to delve into a little bit about what the experience here on the prairies has been, because I do think it's been unique and interesting. We all know that lung transplantation has taken off quite dramatically over the last number of years, and this is the lung transplant volume that we've had in Alberta since the beginning of the program in 1986, and this is data up to 2023. Looking at our current year, I suspect we're going to be, very much in line with what we've done earlier this decade in terms of transplant volumes. We cover a vast territory, and we being the folks in Edmonton, but it's a huge territory of approximately 4 million square kilometers once you start to add in the Prairie Provinces, the territories, and the slices of eastern BC that we often receive referrals from. There are huge logistical hurdles that need to be undertaken when this occurs, including how we're going to assess and manage these patients who have very advanced lung disease. We spend a lot of time and hours and human resources on transportation of very, very sick patients across huge distances. And how to safely do that is still a work in progress that I think we encounter every single time. And then, of course, coordinating care across vast distances with very complex patients requires a lot of effort and a lot of team dynamics that we've invested in. As I think I've alluded to throughout this talk, our current spokes are that of Calgary, Saskatoon, and Winnipeg. And again, there are some shared patients as well back to the Vancouver program, although the vast majority of the BC patients tend to come from Eastern BC, in which case being managed in either Calgary or Edmonton actually makes the most sense for them. And we continue to offer that care. In terms of recipient location, things have remained fairly stable. This is data from 2021, where 3/4 of our patients come from Alberta, but similar sized populations from Saskatchewan and Manitoba as well. And that data again looks very static if you look at it, go forward a couple more years. So in 2023, the majority of our patients still came from Alberta. And I think this breakdown, looks pretty reasonable when we consider the population bases of those 3 provinces. And again, we often have 1 or 2 patients a year from BC. In terms of diagnoses, things are evolving and changing in terms of the patients that we look after in lung transplant clinics. Over the last number of years, interstitial lung diseases and in particular IPF lead the way in terms of the number of transplants performed. Less and less patients are being transplanted for COPD. And the one that's really fallen off the map is cystic fibrosis. So there was 1 transplant in 2021 for CF. And in fact, if you look at 2023, there were none. And I don't even know if we have any CF patients left on our waiting list. The invention of Trikafta and CFTR modulators has really changed the landscape of that patient population. They used to certainly make up 1/3 of the transplant program. So that's the makeup of our pre-patients. What we've also realized over time is that our pre-transplant patients are getting older. The median age of transplant now is over 60 years of age, and we've certainly done transplants into the early 70s with reasonable success. And again, that I suspect this, if we look at this curve in a few more years, it's going to spike pretty quickly once we eliminate CF transplants from what we do. Our patients come to us now with a lot more risk factors and a lot more medical comorbidities. As pointed out here, 1/3 of our patients have underlying coronary artery disease. A number of our patients come to us with pulmonary hypertension and severe gas exchange abnormalities. And I think what's really important to note is a substantial number of our patients are either intubated, trached, or on ECMO. And certainly for those of us that practice in peripheral or in spoke centers, this is an absolute nightmare for us is how to safely get these patients up to Edmonton to await transplant. I think we've all come to the conclusion that they should be waiting up there as opposed to trying to get them to Edmonton when donor lungs are available. I don't think the time course would allow for that, but even to successfully and safely get these patients to Edmonton requires an army and a huge amount of resources. In terms of days on the waiting list, I think we've done a fantastic job over the last number of years with overall a trend towards fewer and fewer days on the waiting list, now down to about 3 months as a median wait on the waiting list. Unfortunately, though, not all patients do make it to transplant. And so we had 16 patients last year pass away on our waiting list. Most of those are at a hospital center, whether it be the ICU or the ward, with very few patients passing away at home. I think that's to be expected for somebody who's listed for transplant. But you can also see that the vast majority of our patients are actually getting called in for transplant with this graph on the left. The vast majority of our patients are being transplanted as ambulatory outpatients coming into their operation, with only about 1/4 requiring hospital care before transplant. I will point out, we don't have the slide, but I will point out too that we have looked at the conversion rate of a pre-transplant patient depending on geography. And so Kieran looked at that a couple of years ago and noted that once a patient was on the transplant waiting list, their chances of successfully getting transplanted was agnostic to the location at which they were coming from. So whether they were a Calgary patient, Winnipeg patient, or Edmonton patient did not matter. And so I think that speaks volumes to the fact that our colleagues in Edmonton look at the waiting list with location basically being censured from their algorithm of why they would pick a patient. And we've done well. I think this is a tremendous reflection of how this program being set up the way it has really serves our patients quite well. So median international survival in the most recent ISHLT registry was about 6.5 years. Whereas if you look at the median survival in our Alberta program or Prairie program, our median survival is over 10 years. And so I think that just speaks volumes to all of the care that we've delivered and the models we've set up. In terms of the program description, I think I've alluded to some of this, but I would like to just focus a few minutes on how our program functions. And so, as was stated, I think numerous times today, surgery occurs solely in Edmonton, but we perform our entire pre-transplant evaluation in one of the 4 spoke centers, depending on patient location. We then present a fully evaluated patient at a weekly MDT for listing. And if deemed acceptable in principle during that listing conference, further education of the patient as well as a 4-week exercise program occurs at the U of A. And typically patients are, I would say, probably 3/4 of patients are status 0 or on hold until that occurs. About 1/4 of our patients, though, are so sick that they need to be actively listed before they undertake this 4-week program. We then monitor patients very closely at our host center with conjoint management with the U of A. And so we leapfrog telehealth and in-person appointments with the U of A. There's joint decision-making regarding transplant listing and active listing or other health monitoring that might be required. And most patients will remain locally in their home center and home city until such time as a transplant is called for, and then arrangements are made with the relevant health authorities to transport them to Edmonton for the surgery. But again, as I alluded to with some of our more critically ill patients, we do get them up to Edmonton sooner to wait for transplant, especially if we think there's a very limited window in which transportation can safely be arranged. Postoperative care in Edmonton is a bit different depending on the provinces. So the Manitoba program tends to take their patients a little bit earlier back to Winnipeg and works on the rehab side things a little bit more in Manitoba. Whereas our patients from Calgary and Saskatchewan, we ask that they remain in Edmonton for 3 months post-op, where they continue to be cared for by our colleagues in Edmonton, as well as undertaking ongoing physio on a near daily basis. But once those time points have elapsed and patients have been transferred back to their spoke center, routine post-transplant care typically occurs exclusively through the host center, with us undertaking discussions as needed, either on an ad hoc basis or at those weekly rounds with our colleagues across the provinces as needed. We continue to feed back vital statistics, including hospitalizations, indication for hospitalizations, deaths, et cetera, back to the U of A at weekly rounds. And when you do the math, this basically minimizes the time that one has to spend in Edmonton to about 16 weeks for their total transplant journey, which becomes a lot more palatable to many of our patients. And so I think this has been very well received by patients. In terms of our program in Calgary, we currently have 5 physicians who split their time between transplant clinic and doing other pulmonary work. We are very fortunate to have two excellent nurse practitioners, one of whom typically is in the clinic and one of whom's on our inpatient ward. This was drawn out of necessity, given that we are actually spread across two sites that are a good 30-minute commute apart from each other. So our outpatient care happens primarily at the Foothills Hospital and our inpatient care primarily at the Peter Lougheed. We do offer consultative care at the other two adult hospitals as needed as well. And then we have a large number of allied health that help us out as well, as including 3 post-transplant coordinators, 2 pre-transplant coordinators, and then we share resources with our other transplant programs as it pertains to social work, dietitians, and pharmacists. We have a shared care delivery model, so patients are not assigned to a particular physician. We run multiple clinics per week and see patients as needed. We also offer a consultative pulmonary clinic to our other solid organ transplant programs. And our inpatient service is combined with our pulmonary hypertension service out of necessity. So there are a number of physicians in our group who do PH but don't do transplant, but they do help us with their inpatient call. And currently our volumes are that we have about 130 post-transplant patients, currently about 100 pre-transplant patients that we follow very closely. And then we receive somewhere between 50 to 70 referrals a year. And of course, many of those don't go on to transplant, but I think it's still important for them to be able to be seen and have those discussions with us. So with that, I'm going to take a break and I'm going to pass this on to Dr. Weinkauf to describe the program in Edmonton.
Thanks, Mitesh. And thanks for everyone for attending and hearing our story. Our program started way back in 1986, so 38 years ago now. And although I wasn't involved at that time, I think Dr. Lean was involved shortly thereafter. And the first transplant was a heart-lung combined transplant, and that was done by Dr. Modry. And then since that time, lung transplants have occurred in increasing numbers, as Mitesh pointed out earlier. And now, I think when I made this slide 2 weeks ago, it was 1,316 transplants, but I think we're up to 1,318 now. And we've averaged 65 to 70 a year in total. I think our best year ever was back-to-back 74 last year and the year before, which was sort of a recovery from the pandemic when we kind of sagged a little bit from 2001 when Mitesh showed we only did 54 that year. So things are picking up again. We, the program over the years, as you can see, has markedly expanded from the beginning when there was sort of one physician, Dr. Lean, one surgeon, and one coordinator, and then has grown tremendously. And I think that's really why we've been able to, A, be as successful as Mitesh pointed out, and B, have improving survival. And so I think it takes a huge team of really talented people to make this happen. And so just to highlight some of these things, our team has 7 physicians at this point. And that includes Dr. Dale Lean, who was the medical director for many, many years, and led and mentored most of us, Dr. Kieran Halloran, Dr. Alim Herji, who's currently on sabbatical, Dr. Ria Varghese, Dr. Jason Weatherald, and recently Dr. Laura Vandenbos, and myself. We have 4 surgeons on the adult side, and the surgical director is Dr. Jain Nagendran, and there's also Dr. Steve Meyer, Dr. Bryce Lang, and Dr. Wei Wang. And on the pediatric side, we do some pediatric transplants, not huge numbers, but maybe 1 or 2 a year on average. And that group includes Dr. Darren Freed, Dr. Mohammed Al-Kalabi, and Dr. Yonkers de Villiers. So a huge number of physicians and surgeons, but you can see there's also a whole host of other healthcare colleagues, including we have 3 post-transplant coordinators and 2 pre-transplant coordinators who are vital to our program. I think we're sorely lacking in FTE. But despite that, people are very dedicated and work many, many extra hours to make this happen. We have 1 social worker, several dietitians, and a group of physiotherapists and occupational therapists that are very dedicated. Jennifer Holman, I think, has been here since basically the beginning of the program and remains here, along with her colleagues. And as Mitesh pointed out, they they do a huge amount of work getting these people ready physically and emotionally and spiritually for this type of procedure. And we demand that they have 4 weeks of intense physiotherapy and occupational therapy pre-transplant and carry that post-transplant for 3 months. And so what we don't have, though, are a pharmacist. We don't have any nurse practitioners, and we don't have any hospitalist type help or psychologist. And you know, even without these, we do manage to run a dedicated inpatient service where we admit every last patient that comes to the emergency room with any sort of non-acute surgical problem, and even sometimes surgical problems to our inpatient service, averaging probably at least, you know, minimum 15, upwards of 24, 25 inpatients at any time, really without any house staff or help. We run an outpatient clinic 5 days per week, and we also do our own bronchoscopies. And so a huge amount of work. I think we're probably the least well supplied FTE sort of program in the world at this point. When I talk to other colleagues around, you know, North America and internationally at meetings. And so I think what this says is that we do a huge amount of work and we're highly successful, even though we're not, I think on a physician side and a surgical side, we're well established, but I think in terms of other people that are able to help programs like this, I think we're sorely under-resourced. And I think that could impact care going forward if we don't get more help soon. So, but because we've managed to have these other spokes, I think that's helped keep us, kind of hang us in the game where we can offload some of the work to the other centers as been described. So I have to thank everyone publicly for their ongoing dedication, both in Edmonton and at all the other centers across the prairies. This is our team. We took this picture actually a couple of years ago now, so it's a little bit old, but some of the people have changed a little bit, but you can see quite a cast here of people that are all super dedicated, and we're proud of this team.
Thanks,
Yes,
Justin. Yeah.
My part of this presentation. So thanks for having me. I'm speaking to you from Treaty 6 territory, but Saskatchewan has treaties 2, 4, 5, 6, 8, and 10 territories within it. Our program is, as mentioned, a spoke and provides similar care to what was described for Calgary in terms of the pre and post management of patients. Our team is 2 physicians. There's myself and Dr. Tam. We have 1 pre-transplant coordinator, which is actually a recent addition for us. We've functioned without that for most of the time that this program has been around. I returned in 2008 to start the program. We have 2 post-transplant coordinators. We do have a dedicated pharmacist and a dedicated social worker. We share those with heart and liver as well as pediatric transplant in Saskatchewan. So it's called the out of province office because all of those groups actually go to Edmonton collectively. So to Mitesh's point about, you know, maybe we could have a broader perspective on this, I think that's absolutely true. At the moment, we have about 71 active post-transplant patients. That doesn't include the few that are in the immediate post-transplant period and are actually still resident in Edmonton at the moment. We're following 67. This is last week. We've added to that since this was collected. And we average 40 to 60 referrals a year for evaluation for transplantation. In terms of the workup for transplant, we very much adhere to the notion of care closest to home. So if the patient's from Regina, I try and do as much of the various testing, et cetera, that would be needed in Regina as opposed to Saskatoon, rather than making them all come to Saskatoon for that. But we have limitations in other parts of the province that does require patients to travel quite a bit. I mean, we have a 650,000 square kilometer province, and we have patients scattered from top to bottom, side to side throughout. So even though the vast majority of the population is centered in the southern half of the province, we have a not insignificant number of patients that are in rural and remote areas, quite distant from us. And in terms of the population of Saskatchewan, we're growing, maybe not at the rate Alberta has been, but we're about 1.24 million people now, and about 17% of our population is Indigenous. So we have a very high Indigenous population compared to other parts of the province, or parts of Canada, pardon me, save Manitoba, who I think is slightly higher Indigenous population. And we're mindful of that in terms of how we do try and take equity and accessibility into account as much as possible in how we deliver the services to these rural and remote communities. The patients, prior to me starting in Saskatchewan, a patient in Yorkton had an 850-kilometer trip just one way to Edmonton, and all of the care post-transplant was actually being managed in Edmonton. So patients were on the highway a lot for long distances, sometimes during the winter when roads are poor and it may not necessarily be safe to be on the roads, but that was the only option available at the time. And so I think from a patient perspective, there's actually been, the ability to provide the care locally has been massive, just in terms of the impact on their lives, the quality of their lives, and the people around them. So, adopting this hub and spoke model, that wasn't my idea. I think this was Dale's idea back in the day. I think has been just amazing for the patients involved in this program. And they universally appreciate the care and attention that is provided to them in Edmonton. And I just wanted to publicly acknowledge you guys as well, that the patients truly value you. And I thank you for providing such good care to them. And I'll hand off to Steve.
Thanks so much for having me here. My name is Steve Grocholski, and I'm speaking to you from Winnipeg, Manitoba. It's Treaty 1 territory, the traditional territory of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the national homeland of the Red River Métis. I've been involved in the program here for approximately 3 years. And prior to that, I did a year of fellowship in Edmonton. The Transplant Manitoba began somewhere around 1994 as a surgical center. And it lasted until about 2014. And around that time, the program was winding down. We had a single surgeon at that time, and he was approaching retirement, and our annual numbers were dwindling down to about 1 or 2 a year. And so I think at that time, the Manitoba program was looking to expand and to partner with Edmonton, and it's been universally a good experience. Our program was primarily limited by a small donor pool and also the single surgeon, but they were successfully able to transplant approximately 128 patients here over the 20 years that it was up and running, so somewhere around 5 to 6 per year. Since 2015, the numbers have improved significantly, and so Mitesh had shown a few of the more recent years where we're transplanting somewhere between 6 and 12 patients a year through the Edmonton surgical program, and so volumes have certainly increased. In the nearly 10 years that the Manitoba partnership with Alberta has existed, we have approached 100 patients successfully transplanted. With this, the total numbers of patients that we're following in the program has also significantly expanded, and so we've needed significantly more resources, locally to be able to manage that patient population. And so our program has expanded from the medical side being 1 or 2 physicians up to 3 physicians now, with myself, Dr. Perhanek, and Dr. Ahmed. And we have a big team of people behind us as well. Although it's not as big as what we would all wish, I think, here. So we have a post-transplant coordinator named Jody, who is really the backbone of daily patient care here in Manitoba. And we have 2 pre-transplant coordinators who have been massive to keeping the program running from the front end as well. We also have access to a dietitian, physiotherapist, and some psych, access as well, although probably not as robust as what we would like. I think with the physiotherapy program being here, we've really been able to allow patients to stay in Manitoba for as long as possible, both pre and post transplant. Our physiotherapist, his name is Greg. He develops a specific exercise program for each of our listed patients in the waitlisting phase and follows up with them regularly. That allows the patients to stay here in the pre-transplant phase for the majority of time, rather than traveling to Edmonton for kind of the prehab phase, as it's known. And then we also like to bring the patients back to Manitoba as quickly as possible once their medical and surgical issues have stabilized, to be able to limit the resource implications for our patients out there. And so I think we're very fortunate to be able to have some of the resources that allow us to do that. There are a few more things that we need to expand on, I think, over the next several years. And so that includes greater access to pharmacy resources here, greater access to clinic space, probably another post-transplant coordinator, and then a few other sort of funding and government-focused initiatives, I think, that should be explored. Similar to what Dr. Fenton had mentioned, we have patients coming from rural and remote areas of the province, and so coming down to Winnipeg for testing and to stay in hotels for that amount of time can sometimes be can sometimes make it much more difficult for patients to even access the resources here in Manitoba, let alone going out to Alberta. And just anecdotally, we do still have patients who decline to be worked up or decline to be listed because of the inability to take time off and to travel for significant periods of time, especially for their family members to be able to travel along with them and to support them along the journey. So in summary, I think, from a Manitoba perspective, our program has certainly grown after the partnership in 2015. And it's been, from our perspective, a very positive experience. Apart from just the growth in the program, having access to greater physician resources to review complex cases and to get feedback, I think goes a long way. Only having a small amount of physicians here in Manitoba, it's really important to get diverse perspectives from higher volume centers, and we really appreciate it.
Thanks, Steve, and thanks everyone. So just quickly, a couple of closing comments.
I just want to really try to, if we can speed along, Mitesh, because we only have 5 minutes for discussion.
Yeah. So I mean, really quick, I think we've demonstrated quite clearly that the hub and spoke model is an effective way to run complex organizations, and I think using this in transplant really has been revolutionary, and that our Prairie Lung Transplant program has really been offering this true hub and spoke care for many years. And like I said, I think this is something that we should probably look at publicizing around the world. These were the objectives, and I think we've hit upon all of those, so I won't reiterate them here. And I'd like to just quickly take a second to acknowledge all the folks that work in transplant medicine. And I think preparing a talk like this just always impresses me how big the village is that's required to look after these patients. And I want to thank all healthcare professionals that do this for a daily living. So thank you all for what you do.
Great. So yeah, thanks to all 4 of you for great overviews of kind of the strengths and the challenges of this setup. We have great attendance here today, so I do want to make sure I've opened the floor for anybody who wants to ask questions about kind of this and the logistics and what the lessons are for other organ groups. We have a bit of time for kind of a roundtable here, and I think if we end up going a little bit long, I think that's okay. But just to start things off, what from your guys' perspective, to me, one of the core things about this is getting patients to lung transplant specialists, and because I think that a big difference between us and the United States is that we do lifelong specialist-driven care, which has been shown to be advantageous for patients in terms of literally their outcomes. Whereas in the United States, patients can be sort of left to fend for themselves through primary care or what have you. So what do you guys think the role is of this as a specialist, focused organization is, and what do things look like moving forward into the future with, at least for the next 10, 15 years, looks like the increasing, collapse of primary care in Canada?
I mean, I'll go quickly and open it up to the others, but I think you're absolutely right, Kieran. I think I personally view, most patients who have had a transplant, their primary care physicians, even if they have one and they're lucky enough to have one, aren't super excited to look after these patients and make drastic changes or do anything, medically speaking, with these patients. And so I envision transplant as being the medical home for patients. And I think, in an ideal world, we would have a setup where, their mental health, their dermatology, their, every facet of things, vascular risk reduction, all of that occurs through the transplant lens, right? And with specialists who know transplant. And that doesn't mean we have to be the ones to do it, but I think it would be great to have setups where partners in things like general internal medicine or psychiatry are intimately involved in our programs.
I just want to highlight, and people can feel free to chime in on that point as well. Donna Veldhoven, who's one of our patient partners, has raised a really good point here, which is, and this is not to raise a black mark, but a commonality among all spokes and hub, is the lack of mental health supports. And one of the consistent things that we see in lung transplant, and I think in other organ transplants, is that we see a lot of the quality of life domains normalize or get close to normal. And that's very satisfying to see, physical, et cetera. But we see these persistent psychological and psychiatric abnormalities in transplant patients. And I think that we have been very, at times fortunate, but when we lose the resources, very frustrated at our inability to access, routine, rapid mental health resources, particularly the psychologists. Our psychiatry colleagues are great here, but we would really love that too, to have psychology and the emotional and mental well-being of the patients take a bigger role. So we're very much on the same page, and I don't want to speak for the other programs here, but I'm almost certain that is the case there too, that they probably struggle to access these resources despite identifying issues. It's just hard to enable those. So I think from a funding perspective and a design perspective, we absolutely agree. We'd love to see that become a bigger part of the focus.
Here, here. I mean,
I'm sure. I mean, it's very frustrating.
Yeah, Donna's point is spot on, that it's a gap, and a big gap, because there is a lot of baggage that comes with this for patients at times, and it's difficult. And I've tried to build, partnerships and relationships locally to try and provide access, but it's very, very challenging. And, and I'm not even sure what the best solution is, whether it's a dedicated funding stream for that kind of care to be provided, because I'm not sure that they're, like, I know from my work as a administrator that we have trouble attracting psychologists into the health authority in Saskatchewan anyway, because the remuneration is just very different from what they would make in a private practice setting. So I feel like I need to build bridges in that space, but it's very challenging, as you've pointed out.
Yeah, Mark, that's been exactly the same problem. I think we've had opportunities to hire, but after a short period of, realizing the challenge of the work and the difficulty of the work relative to private practice, it's not equivalent, both, job satisfaction and remuneration.
And I should point out, Karen has pointed out, Karen Doucette, the section head for transplant, has pointed out that that they have actually had a role posted to hire someone here, and they haven't had any applications. So it probably does speak to it being a broader, availability issue in terms of the staffing, as well as it being recognized as very important. Sean from the ATI also raised a question here to the SPOKE programs and those supporting northern and remote patients out of Edmonton. How do you view initiatives like Breathing Space, which is the sort of dedicated facility for lung transplant patients and families to stay, which is being supported and funded by the Alberta Lung Association? What's kind of your view on that, and what do you see the pathway forward for supporting patients locally while they do have to be here? And it's 16 weeks. You're right. It's minimized compared to Toronto, where you have to move there permanently if you want to transplant there. But it is not small and not disruptive for patients and their families. So, what are your guys' thoughts?
Well, I'm a big fan of the idea. I've offered the Alberta Lung Association if they want me to get involved and help them to shoulder tap as much as they want. I think it's super valuable for the patients, because that's one of the uncertainties for them is, where am I going to stay? How much is it going to cost? And this takes some of that anxiety away, and I think does provide an environment where they're going to be with other people that understand their experience as well, which I think is also very valuable. So any way we can support it from Saskatchewan, I'm happy to get behind it, because I think it's incredibly valuable.
I agree. I think that's the biggest barrier for patients in Manitoba, is being able to survive in Edmonton, for the time that they're there, and for their families to feel supported when they're out there. And so anything that we can do to make that program more robust, I think we would be willing to help out.
And I have to say, it's pretty heartbreaking to hear these stories that you guys say of patients who just, and you never tell us about them. We never hear them outside of this context. These patients who just say, I'm not going to do this because of the logistics and the cost. So that's quite disturbing and kind of heartbreaking to hear about, that we have a functional screen like that in Canada, where we've tried to break down all the screens.
They often don't say it like overtly, but it comes out in other ways. That they can't take, their partner can't take time off of work, or these sort of things. And so we do have a social worker that works as part of the Transplant Manitoba program that tries to help them out with other resources as well, but it still does remain a barrier for some of our patients.
Sylvia has made a really good point here in the chat too, that really related to the lack of psychologists, the social workers, our social worker, Skyla, and I know the social workers in all the other programs that you guys can speak to, they basically have taken on this mantle. In addition to all the complex work that they do, they have in some ways become psychologists for our patients, which is very hard, but they have risen to the occasion, and we can't do this work without the exceptional social workers that we have, that have enough on their plate just from a social work perspective and all the complex care logistics, but they have really risen to the occasion of the psychological needs of the patients too, and consistently highlight that, and highlight the need for, if psychiatric consultations required, they really make a focus on that. So I do want to give you guys, many of whom are in attendance today, a big shout out from that perspective.
Thank you, Karen. If I can just add, Sylvia here, our social workers in transplant are very specialized, as you know, and most of us are working at a social work 3, and our education is MSW level. So just for most of us, and if not by training, by experience. And I'm just going to comment on Manitoba. I know some of the work we've done with Manitoba patients, it makes me really curious, because I know Saskatchewan does have supports coming from the Telemiracle, and we have other resources. But the last I worked, now this is a while ago, so Skyla can correct me, but they were doing box socials in Manitoba for their families. I thought, this is so something, how they managed to, thank God for GoFundMes and different things. But so much is relying on the families. And so I really appreciate the families and all that they do to support their patients, and definitely our mutual programs. Thank you so much.
I agree in Manitoba, and thank you for the social workers. They do really fill in the gap for psychology support that we're lacking here. We do have patients that really rely on their community to help fund, support people to go out to Edmonton, and so it's I think most clear in patients that live in northern communities. Often you see groups of families come together and help to support the patient going through it. There are box socials and things like that occur as well. And there's often an attempt to find alternative funding sources as well. I know I have a patient that is an artist, and so we're trying to work to figure out if he can get some of his art and stuff in a gallery that can eventually go on sale and all of that kind of thing. So.
When you guys were saying that you have people openly or not quite openly declining because of cost, that really struck me, because I don't have that here. I very deliberately tell patients, don't let money be the barrier, because we have community-based organizations in Saskatchewan that will get behind patients and provide support. So Kinsman is just one of several. And yes, people do GoFundMe and things like that. But, I don't recall anyone saying no because of money, to be honest. They always seem to find a way. Maybe there's someone that has declined and just not made that clear to me, but I think we must be very lucky in Saskatchewan by comparison.
Out here, we try and also make the case that, we can often try and work with them and try and find some funding sources, not necessarily from government funding, but working with the social worker and stuff and figuring out what is available. I think part of it is it comes across as almost like patient guilt for putting their family through, or the sense that they're putting their family through hardship to be able to have a successful transplant, and I think that's how it comes out the most.
Oh yeah, I mean, a straw poll of my patients is out-of-pocket expense associated with a transplant is between $10,000 and $15,000, depending, which may include things like I'm paying rent and a mortgage, for example. But it's not inexpensive. But fortunately, we've got supports here that will help offset that.
Yeah, and I should mention, through social work and through transplant services, we have these accommodations very close by the university that people have access to at very low cost, very subsidized cost, but it's not zero. So it is a consideration for people. And I also just want to make note, Ann Halpin from the HLA lab, made a really good point that this affects, the way we've designed this program just affects all kinds of people at this center and at the other centers, of building bridges and liaisons between HLA and transplant infectious disease, and at the nursing level, at the physiotherapy level, at the social work level. All these people have to be collaborating and building, bridges across areas where they otherwise would not. So it is, if you ever diagrammed out all of the people involved in this, it would look like an absolutely remarkable thing, and a lot of them we haven't even touched on today, because it would take way longer than an hour to illustrate it all. So yeah, thank you to and many of them were in attendance today, so thank you to everybody who was in attendance today. We had multiple surgical colleagues in attendance today, and really our whole team. I'm conscious that we've gone 10 minutes over, and remarkably, we still have 32 people in the audience. So thank you guys very much for staying long. I'll give a final opportunity for last comments from any of the speakers. Anything you guys wanted to leave off with, or any final thoughts?
I just want to say thanks again for having us, and for having us part of the program out in Edmonton as well.
Yeah, absolutely. Thanks, guys.
All right, well, thank you, everybody. Thank you to our four speakers. This was a fantastic session. I wish we'd had a little more time for a roundtable because it's always the best part, but and thank you to everybody for attending. Feel free, everybody, I know all of our speakers would be happy to receive emails and questions if you guys want further discussion points.